Welcome everybody. Welcome back. We are now on the 17th item, which is the West Yorkshire and Harrogate Local Maternity and Neonatal Services. And this will be presented to us by Bev Geary and Debbie Gibson. We've made reference to maternity services throughout the day actually, but now we're going to have some concentrated time on receiving some information about where we are.
Thank you, Chair. So I'm not going to make, I was going to talk about the national review. We've talked about that. I've offered some assurance to the board and to people that have dialed in around the assurance of the two organisations that are included in the review and some of the work that's been undertaken. Therefore, I'm going to hand over to Debbie to talk about the work of the LNMS. Thank you.
So, good afternoon, I'm Debbie Gibson. I'm the Director of Midwifery for West Yorkshire ICB and the Programme Lead for the Local Maternity and Neonatal System. So I presented at this board previously, and the paper that you've received today is a detailed update on the progress of our services. And it demonstrates the progress being made in line with the 3-year delivery plan for maternity and neonatal services. I'm just going to bring out some of the key highlights from the report really, and then allow some time for discussion. So it highlights in the report the commitment to ensuring the voices of our service users are heard and that meaningful action is taken in response, as well as the ongoing development of the maternity and neonatal voices partnerships across our system to bring us in line with the national frameworks. It provides an update on our work to address health inequalities. This work does not sit in isolation, it's threaded through all our work streams, and there was a detailed update about health inequalities at a previous board this year. Some of the particular initiatives that we're working on at the moment in health inequalities include appointment of specialist roles in trust to tackle inequalities, as well as roles to provide additional support to those most in need. We're currently developing an interpreting and translation toolkit, and we're also developing a complex social factors resource. This will provide tools and pathways to enable identification of and support for those most in need in our services. There have been significant improvements in our midwifery workforce numbers over the last year, with many trusts currently over-recruited to ensure as many newly qualified midwives as possible were appointed. And we continue to focus on retention, development and well-being of the whole maternity workforce. We've recently done some work on the maternity support workers framework, ensuring that they have the skills they need to deliver more enhanced roles and to provide them with additional security and development. We're also currently working on our labour ward coordinators framework, which ensures that the labour ward coordinators, who are the shift leaders in the intrapartum environment, have the skills required to deliver safe services. We continue to work together as a system to monitor data, to learn from incidents, as well as good practice, and implement initiatives to improve outcomes, including the Saving Babies' Lives Care Bundle. We have a maternity services dashboard that has a health inequalities lens on all of our metrics, and it also has some clinical metrics on that, and it enables trust to look at that data and see exactly where their areas are, compare themselves to other trusts, and enables us as a system to see where we need to target some of our work. And it enables us to drill down to specific population, to where we've got particular focus, particularly around like smoking cessation, for example. With our smoking cessation, we've had quite a lot of work around the Saving Babies' Lives Care Bundle, and the rates have reduced significantly over the last few years, which is good progress, and that is one of the key modifiable factors in reducing stillbirth and neonatal death for babies. Our mortality rates have reduced currently, and currently the stillbirth rate is 3.4 per 1,000 births against a national rate of 3.1. And our neonatal deaths are also reducing, currently at 1.9 per 1,000 births, and that's been continuing to reduce over the last year. And these reductions, so we can't exactly say what these reductions are from, but we know that all the work that's been ongoing, the Saving Babies' Lives Care Bundle, is a key factor in ensuring we're improving those outcomes. We have ongoing work in maternal mortality, and we've got a North Eastern Yorkshire regional review in progress. The findings of that should be published in spring next year. We've also completed a deep dive of perinatal suicides, and we're finalising the key actions to take in response to that. Many of the recommendations that we found actually align to the findings of the latest Embrace report that was published this month, and that's the Embrace Maternal Mortality and Morbidity report. And there's some key areas of work that we'll need to look at, including interoperability, increasing staff awareness of of mental health and recognition of red flags, as well as systems working together and disciplines working together. And on that, we continue to work towards improving our interoperability, and we're progressing the implementation of the Yorkshire and Humber care record. That's an electronic record that enables the different electronic systems across our different trusts to be able to talk to each other. So, and finally, just to note that some of the risks listed in the paper will be closed or reduced soon. So there is 2197, which is the risk relating to the birth centre in Pontefract. That will should be able to close now, but following the completion of the formal consultation. There is 2453 in relation to the pelvic health service. That risk will reduce because services are due to launch in the next few weeks, and over the next few months it should be able to close completely when services are fully established. And then risk 2551, which is the risk of not listening to service users meaningfully, will reduce as there's multiple mitigations in place in trusts, and we have an action plan in place to improve the MNVP structure. We also have a local health risk that's not on the corporate risk register in relation to the maternal medicine network and the staffing in that network. That role has been now appointed to, so that risk will be able to close. So the board are asked to accept the update on the progress and the priorities of the West Yorkshire and Harrogate local maternity and neonatal system. Note the risks to the delivery of some of the national work streams and the mitigations to address these that have been detailed within the paper. Note the emerging risk regarding the infrastructure as a result of the changes to NHS England and the ICBs, and be assured of the collective commitment to address health inequalities of women and families of West Yorkshire. Thank you. Any questions?
Thank you. Thank you, Debbie. Very, very comprehensive. And I'm struck by the fact that our first strategic priority is listening to and working with women and families with compassion. So really, really appreciate that. Any questions? Comments? Fatima, Hannah, Richard?
Hi, Debbie. Thank you for that really helpful and comprehensive summary. I mean, I've got two sort of questions based on the risks that you've just articulated. One of them is about 2454, which is the sharing of medical records, and whether we've got any sort of timescales or a little bit more information about the mitigations in place for that. The second one obviously refers to the risk regarding sufficiently listening to service users and staff, which is unsurprising coming from me. We mentioned prior to sort of your arrival, when Rob was doing his chief executive update, about the concerns that were flagged via the VCSE voices that were fed into the evaluation led by Professor Dame Donna Kinnair. Obviously, we've had Gary Jevon, who's part of your team, an incredible leader, come to the VCSE voices to talk about opportunities for collaboration. It's just a further offer of support to really support this work and to use those VCSE voices as an opportunity and conduits to diverse communities in the interest of rebuilding trust and supporting the work taking place. And then my final one is, in the assurances that you've given, how will we know that we're getting there? Because all our staff are working really hard. We're getting loads of reports and loads of assurances, and yet there's still that level of understandable concern. And I just sort of wondered whether there are ways in which we can demonstrate to the board, but also the public watching, that we are making a difference and that people will feel the change. Thank you.
Thank you for your comments. So first of all, you mentioned the interoperability risk, or the digital risk. We are making some progress with that. We are moving towards the Yorkshire and Humber care record. We have one of our trusts already has access to it, and we've got another trust that imminently will have access to that. All trusts are feeding some data to that. And actually this stage, really, it just needs that trust engagement to just get on board. And we should have something quite soon, hopefully. But it just depends. We've got to join the dots in a few different places in the trusts. But really, this is not just a West Yorkshire issue. This is an issue across the country. And we're really asking for some joined-up working with other ICBs as well, certainly in the Yorkshire and Humber patch. The maternal medicine network that I mentioned, that's a Yorkshire and Humber, and it's really important that they are able to see records of women from across the whole Yorkshire and Humber patch. But at the moment, we kind of working a little bit in isolation, and we really need some collaborative working in that. And we've asked for some regional support with that as well, because some digital leads there. As a timescale, I'd hope to have some timescales. I think we need to get a couple of these extra trusts on board, see what that's looking like. Once we know what that looks like, then we'll be able to have some clearer timescales with that. Obviously, the ideal would be all trusts being on one system, but we're not there. So in the element you said about listening to families and further support, absolutely welcome that. I think part of our strengthening our maternity and natal voices partnership is absolutely pivotal with that, enabling those partnerships to be a team that networks with the voluntary sectors and other organisations to bring all that feedback and to hear it and have the capacity to make meaningful change within trusts. And I've actually just been at a meeting this morning with some of our partnerships looking at exactly how are they getting the feedback about the impact they're having, and we've talked through some ways that can happen, and about at the minute it feels almost insurmountable. There seems so many things that we want to address, but looking at what are the prioritising and trying to work on some key things. There's some really good initiatives happening. For example, this morning they were talking about some work that they're doing around informed consent, which are absolutely being co-produced with service users about how we change the language and ensure we're getting that information there. And then your last point was about how we know we are getting there. And I think there's various different metrics. I think looking at outcomes is part of that. We're absolutely looking at mortality and morbidity rates. That will be part of it, but it's also looking at some of the data we have around staff satisfaction and patient satisfaction. We have our annual CQC patient surveys. We also have our MNVPs that bring that much more real-time surveys, as well as working in the wider communities to know how is it feeling for our service users. We have staff surveys as well that can help us give that, but it's that just, surveys have only so much value. We will start to see some things through those metrics, but it's about working with our providers and having that relationship and starting to see the service changes. And we have seen that over the years. I mean, I've been in the LMNS 2 years now, and I've previously worked in the NHS regional team, and I've worked at that system level, and I've seen those changes gradually happen. Unfortunately, these changes do take time because we're talking about changes in culture, but you do see that shift, that there's that realisation of the change that needs to happen and trust starting to work through it. And certainly the value that trusts are now seeing, that from a leadership perspective, are seeing the value in hearing service users and meaningfully putting that into action is really, really shifting. I know we're not quite there yet, but there's been a massive change. Okay, thank you.
Hannah, and then Richard.
Yeah, just to follow on from Fatima's point and your response, I suppose just to highlight the report that we did in March, which hopefully, where people kindly shared their experiences and recommendations from people's perspective. And one of the things we said in that was around the vital role that maternity voice partnerships play, but the need to be properly resourced to enable them to engage effectively. And in that report, we highlighted a number of groups that which the recommendation was to focus on. So more widespread understanding of the experiences of Black and Asian women in West Yorkshire, people with wider social factors affecting their lives, such as substance dependency, domestic abuse, insecure housing or homelessness, being in contact with the criminal justice system and extreme poverty, disabled people, including people with learning disabilities, their carers and or partners, fathers, LGBTQ+, especially trans and non-binary people, and people who are deaf or hard of hearing. So it'd just be good to know that we're, in those partnerships, that we're focusing on hearing all experiences and not just relying on surveys, as you've just mentioned.
I think everyone else will take a few questions and then you and Debbie can respond later. Thank you for that.
Be there. Richard.
Thank you for the report and for all the work that's been going on, and it's good to see some progress around this area. Just two questions. One, we've referred to a number of times in the board meeting around vaccinations, immunisations. You'll be aware that mothers and babies particularly are very vulnerable to flu, to measles, to whooping cough, and the important role that midwives play in promoting, advocating and ensuring vaccinations are taken up. And I just wondered what work we're doing to try and ensure that that doesn't dip further and that we do actually address this gap and the vulnerability that that's created and which can actually affect perinatal mortality. And the second thing is just going back to the digital thing. GP practices often complain sort of, that they don't get the information from midwifery teams and others sort of, flowing through into their records, and they may not even know that their patients are actually pregnant because the majority of the care is delivered by midwives, which is a good thing, but we want to know that communication so that we can engage with our patients appropriately. So I think it would be good if we can continue to work on that interoperability between GP records and the midwifery record as well, and that would be really helpful.
Not a question, just to thank you for referencing the work we're doing in Bradford around maternal suicide. It's not, I don't think it's very well known, the tragedy of maternal suicide, particularly during that perinatal period. And I just wanted to give you some good news that last week I was part of an interview panel for a substantive consultant for our perinatal services. And it was a fantastic appointment, and all the way through the interview she talked about babies and mothers and families and how that absolutely has to be the centre of the work that we do. So just some good news, because those are quite difficult to appoint to posts.
Yeah, thank you, and thanks for the report. Just, bearing in mind various conversations that we've had over a period of time here around the services and obviously the recent investigation that's been announced, I was interested to understand kind of the risk around 2551, I think, in terms of needing to have commissioned the LMNS, local NVPs by the end of March. I guess my question will be, as well as the new risk, what do you need in order to be compliant with that? What is the ask of us, and what would be required to do that? And I think also you talk about an emerging risk, obviously, in terms of impact of the organisational change and uncertainty, and how that could have had adverse consequences into this space. But again, I guess my plea would be kind of, what do you need us to do, or what would need to be different for us to mitigate against that, rather than just accept it's an emerging risk because of all the change that's ongoing?
Yeah, just a couple of things. So thank you for the report. Really good news on the workforce. I know that's been a struggle previously at the Quality Committee. There was talk about the Maternity Voices Partnership and resource requirements. So just picking up on Jane's point of whether that's been addressed. Secondly, in terms of health inequalities, really pleased to see a lot of commitment in there to tackle that, but there are some areas where we're still talking about posters, etc., and obviously language translation, assuming people can read, etc., could still be really problematic. So I think where we've got specific demographics, as highlighted by Hannah in the Health Watch report, in terms of specific work with those communities and co-producing the solutions together, be good to hear what we're doing specifically about that, to make sure we don't fix the wrong problem or fix one problem and create another one. Thank you.
This is in response to a couple of comments with regards to the share care record and the data. I think we are working with all the organizations, because earlier this year, all the organizations within our page, they set a commitment that they will do the minimum viable data set, which is required for any organization to share their data to be done by the end of this year. So we are working with everyone. And of course, at the moment, the progress is slow, but we have focused a lot in the last 1 or 2 months to get these things faster, and then get this commitment fulfilled. So we are working with them to have the realistic timeline, which will enable us to know exactly when this will be done. Once we have the MVD, then I think a lot of the data sharing part would be possible. Another part is that I just want to also remind everyone that we are also working on the federated data platform, which provides some of these solutions with regards to sharing the data. It's a national platform, and then we are partnering with our national colleagues on this one as well.
It was a really helpful initiative to know about. Debbie and Bev, would you like to just respond?
Yes, so there's quite a lot there. So first of all, there was with the reference to the Health Watch report, absolutely we have looked at that, and yeah, have we addressed all of those recommendations? Probably not, but we are aware of them, and that's part of that MNVP resourcing, and that's the ongoing work that we need to be able to get that. There is absolutely some focused work happening in our communities. Just off the top of my head now, we know there's been some focused work with our Gypsy and Traveller communities to ensure that we're hearing their voices, to understand their needs, as well as with our women in prison as well. And there's also been some work in some of our Muslim communities as well, and it's absolutely been going out to those communities. They've been going to mosques and things like that to try and ensure that they're reaching out to those. So, and as we expand that maternity and neonatal voices partnership, that will open up the opportunity to be ensure we're engaging with those different communities. So yeah, I recognise that and hope that answers that question and gives some reassurance there. I think the next one was about vaccinations and immunisations and the role of midwives. Absolutely, they're really important in giving that public health messaging. It is part of the midwives' role to give that public health messaging, and some midwives do give the vaccinations. The complexities come is when it's about sometimes actually having the clinics for the vaccinations can be challenging at times, and it's managing that when we know that midwives are already workloads are already overstretched and they don't always have enough time to do the clinics that there are. So there's some practical complexities that we have at times. We do keep an eye on the data with the vaccination. We do work with the regional team to look at that data, and we do have sort of key vaccination champions in each trust that we link with to try and ensure we're moving that forward. And I think the other point that you'd raised around the GP practice communication, yes, that absolutely needs to be part of that interoperability. And I think, from a midwifery perspective, I think the fact that a lot of midwives don't actually have clinics in GP surgeries has absolutely made a difference to that availability, to have that relationship with GPs, which we know has caused a bit of a gap. So, anything that we can work on together to improve that. Midwives work in various different places, and it's more and more challenging to get accommodation to hold those community clinics. There was the emerging risks. I'll come back to that in a moment, but I think there was a bit about the MNVP. How do we meet that? I can't remember who asked that, but I think the ask of that really is we need some investment to be able to provide that. We've drafted a proposal which has been agreed in principle, which is it strengthens the MNVPs that we've got there. It ensures that they're all appointed to an approved job description, that they're all appointed in the same way, that they have the right skills and ability to do the role, and that are supported by a clear infrastructure, that we have MNVP strategic leads that have enabled them to do that strategic change, but they also have engagement leads that sit under them, and that then will work with communities to ensure we've got that team approach. So it needs, as I say, we have got a paper that's been agreed in principle as in what the model will look like, but it needs some investment from that to be able to do that. And I think your point about the posters, I absolutely acknowledge that posters are not always the right way forward, and we do work with our communities, and again strengthening those partnerships and working with communities. Just at the moment, I've just got in my inbox today the first draft of a video that's going to be for service users. We've done it first. The first draft is in English, but we have got people lined up in Romanian, that can speak people that can speak Punjabi and Urdu, and I can't remember what the fifth language is, but we've picked like the 5 top languages that are used in our communities, and they will be recorded in those languages, because we know that actually some people don't read, and then once we've done that, we're going to use AI to translate into other languages as well. So, and if this goes well, we'll look at all the videos, and this first video is going to be about reduced fetal movements, because we know some of our populations don't always present in a timely manner when they've got reduced fetal movements. So yeah, that's the first step in that way, but if this works well, then we'll look at different ways, and we've absolutely worked with communities to look at what will work for you, who will you listen to, how does it need to come across. So, but there's lots of things there. I think was just a comment on it about the digital, not really a question, and there was just the emerging risk, I think, for yourself.
Yeah, so I just want to add that this is a snapshot of some of the work that's undertaken by the LNMS. There are provider boards that have got oversight of really detailed work in every part of the system. And this is, as I've said, it's just a snapshot. So there's some amazing work happening in Bradford in terms of the interpretation services. They came to our system quality group to present that, and we presented that widely to lots of other services. So YAS, for example, Yorkshire Ambulance Service, for example, because the work that, you know, it was co-produced with, you know, with system across the system, and it worked fabulous. So that's just one of the things, and the high level impact is not always measurable. So that's one thing. And the other thing I wanted to talk about in terms of the emerging risk that Jane's flagged is, I think at this board, I previously said we've got 2 members of staff in the LNMS. Debbie was one of them, and I think there was somebody else because of sickness, etc. We built up a fantastic team in the LNMS. We've just talked about organisational change. There will be an impact. We do not know what that is yet. There is work nationally, and there's also work at regional level to ensure that we have got a good system of work, and whether that be across, well, it's got to be across the region, but until there is some more detailed work undertaken, that will remain a risk, because we can't reduce by 50% across the organisation and not have some impact. So there are our regional chief nurse sits on the National Maternity Board, so we're trying to influence at West Yorkshire level into the region, and as soon as we are aware of what that national model will look like, then we will absolutely implement it. And we're also hopeful that there may be something comes out of the Baroness Amos national review. So that's all I wanted to add. Thanks, Chair.
Okay, thank you for the report, Debbie and Bev, and for the questions and comments made, and for the way you responded to those. So it's very clear that a lot of work is happening, a lot of work needs to be done, and some work is happening at regional and national level that we are waiting for the results of. And then I think Fatma's comment about the Dame Donna Kinnear's report and some of the recommendations will be helpful to see how those play out locally and regionally for us as well. So thank you very much indeed. What we need to note is we've accepted the update. We note the risks and the emerging risks as well, which are unknowns, but we as a board have to be cited on those as they appear, and also have some comment and mitigation around them. And we are actually assured by the collective commitment to addressing these health inequalities in maternal health. And I think we've demonstrated that from our discussion this afternoon. So thank you both very much. We are now on to the next item. I do apologise for the way we've sort of overrun, but I think that is in part to do with the quality of the conversations we need to have at this moment in time. So I'm going to pass to Deborah Taylor-Tate, Jonathan Webb and Laura about system performance. But am I going to Laura first?
No, I do.
Okay.
Shall I go first?
Please.
Yeah, okay. Thank you, Chair. Hi, everybody. For those of you that don't know me, my name's Deborah Taylor-Tate, and I'm here deputising for Lou Olga, who's the Interim Director of Planning and Performance. So at the end, in the interest of time, I'm just going to pick up on a couple of the highlights from the report. It's very long. There's a lot of slides in there and an incredible amount of information. So I suggest in the interest of time, if people have got any questions, it may be better that I can take them away. I was going to just pick up on urgent and emergency care, electives, cancer and mental health. I think we've talked about those a little bit in the Chair and the Chief Exec report. And I think something that Rob raised in that report is really important, that these are metrics. They're not always just reflective of all the work that's going on in all those organisations. And in many of those, all those organisations, there's some really good performance across all those other services that don't always necessarily impact on the ones that I'm going to talk about. These are also, I think it's important to note, are part of what Rob talked about, the National Oversight Framework. So these high-level metrics are the ones that organisations will be monitored on. So it's important that we understand what's going on across those. But as I said, it's not always the biggest, it's not just the biggest picture. So if we look at urgent and emergency care, and obviously that's something we're tracking very closely as it's getting cold outside and winter is coming. I had to get that bit in. So for our 4-hour target as of June, we were achieving 77.3%. Our target is 78, so our plans are on track. But there is some further work to do in a couple of our trusts, and that's Airedale and Mid Yorkshire. But really good news is that we are 8th nationally out of 42 ICBs, so we benchmark incredibly well around our A&E target. There's been a lot of focus on the 12-hour target in A&E, so that's all people not waiting longer than 12 hours, and the target is 10% of people, of all the attendances. And again, we do track incredibly well with 5.1%, but there is a variance obviously across our trusts from 4.9 in CHFT up to 7% in LTHT. But obviously, as I said, we are tracking this because it's important as winter comes. Around our electives, there's a couple of targets here. 52-week waits. We haven't 52-week waits. That's people waiting 52 weeks for an operation. We are 18 out of 42 ICBs. But I think what's really important to note is in June 24 we had 37,000 people waiting, and now in May we only have 17,000 people waiting. So that is it's still very high, but it is obviously a 54% reduction, and the majority of those people are complex cases and waiting for across those specialties. 65 weeks, again we have made an incredible reduction with 1,201 in June 24, and in May 25 we've just got around 112 people waiting over 65 weeks. And again, this is in certain specialties around ENT, plastics, dermatology, spinal, but we are projected to reduce that further to under 100 in Q3. Around cancer, for the 2-week waits, we benchmarked 6 out of the 42 ICBs with a current performance of 87.3% of all people being referred, being seen within 2 weeks. And the 28-day diagnosis from referral target is now 80% by March, and at the moment we are tracking at 77.1%, but we are on trajectory. The biggest pressure for that, as you would expect, lays in LTHT, but there are regular meetings with NHS England and the ICB, and there is a positive trajectory to recover that in quarters 3 and 4. The 62-day remains a challenge for us. We currently benchmark 11th with a 72% against the 85% target. Again, unfortunately for LTHT, majority of this sits with them. And again, it is the complex cases, but we do know that they're supported heavily by NHS England and the Cancer Alliance, especially the priority tumour pathways. So a lot of positive work going on there. Just last one, I'll pick up on a bit of mental health. So our talking therapies, the target for our talking therapies is 48% of people being seen. We are tracking at over 50%, so our performance is incredibly well, and we see 94% of people within 6 weeks and 97% of people within 18 weeks. So again, we've made some good progress. I know it's been a priority area over the last 3 or 4 years. With our out-of-area placements, that continues to be a challenge for us for varying reasons, and there was 31 people in May 25. Earlier in May this year. It's an area again that we will continue to monitor, especially as we go into the winter months, where we know some of our extended delays in A&E are for our mental health patients. So they're the main things that I did want to cover. I don't know if anybody's got any questions, Chair, or we're going to go straight to Jonathan.
Yeah, we go straight to Jonathan,
Yep,
and then
fine.
take the risks. Thank you. Jonathan?
Okay, thanks, Debbie. So I will talk through a little bit of the detail, but I suppose just in headline terms, in terms of the system financial position, probably 3 things. One is we are still off plan as a system in terms of our year-to-date delivery against plan, but at month 5, that adverse variance is slightly less than it was at month 4, but we are still off plan, so that's the first thing. Second thing is all statutory organisations are still reporting delivery of their plan by the end of the year, which is a positive thing. Third thing, though, is that does include organisations carrying some significant financial risk. So that's, I suppose, that's the summary. But if I just talk a little bit through some of the detail. So the numbers that you've got in the report are based on position as at the end of month 4. Occasionally we'll refer to where it's up to for month 5 as well. That isn't in the report because that's been secured since the report was drafted. So at the end of month 4, we had a planned deficit across the system of 25 million, and we achieved a deficit of 37 million. So that's 12 off plan. That 12 was made up of 3 million adverse variance in the ICB and 9 across providers. And that did signal a fair deterioration from month 3, in part driven by the industrial action costs that were incurred in month 4. And I'm going to say at the moment, but there doesn't appear to be any national funding for those industrial action costs. So at the moment, the assumption is we will have to find a way of managing those within the ICB, within the system. So we were £12 million away from plan at the end of July. The position at the end of August is that 12 million adverse variance has reduced to 9. So it's still 9, so it's still a big number, but it's less than it was at month 4. What we are still including in our figures is an assumption of full receipt of our deficit support funding. As the board have been previously briefed, we are expecting to receive £49 million this year from NHS England to support our deficit. That's assessed and paid for on a quarterly basis. We were successful in securing that for quarter 1 and quarter 2. NHS England are currently in the process of determining which systems will or won't receive that support funding for quarter 3. So we'll understand that within the next week. So obviously that would be 12.5 million, a quarter of that 49 million. So that's the position in terms of the overall I&E. In terms of our efficiency, and it is efficiency delivery that in part is driving that adverse variance. We are behind plan year to date in the ICB, and we are behind plan year to date in most of the NHS providers. Nevertheless, we still are forecasting to deliver 427 million of our £433 million target. In terms of mental health investment standard, the confines of that and the definition of that standard means that roughly 10% of our allocation is deemed to be spent on through that standard, so around about £604 million. That is our plan, and that remains our forecast, which is a positive thing to retain that level of investment. Agency spend is another area that NHS England quite rightly have put increased focus on this year, as have we this year and in previous years. In terms of our month 4 position, we are not far off plan, I think is the best way to describe it. And we are forecasting to spend slightly less than our plan by the end of the year. So the level of financial challenge and risk across the system is fairly significant, and we're having detailed conversations with those parts of the system where that risk is prevalent. At the end of month 4, it was around about £80 million in terms of risk that organisations were carrying. That was predominantly in 4 of our 10 NHS providers. And really what we'll continue to do is to take that risk-based approach to financial management and assurance. We're continuing to work closely through our places and through into organisations, and increasingly we are ensuring that NHS England are around the table and are aware of not only issues, some of the actions that we can take, but also some of the actions that they might be able to take to support us. So that's where we are for month 4, Chair.
Did you want to do the risks? Okay, if Laura does the risks, and then we'll take questions and comments.
Thank you. Yes, I'll just give a brief introduction. So the report reflects the position in terms of our risks at the end of quarter 2. You've got details of those risks that are on our corporate risk register, together with place risks that are high level or risks that are common to more than one of our places. All of the risks have been through detailed review steps over the cycle, and there's quite a bit of narrative within the report that summarises those review and discussions. There are 63 risks in total that are there for review, and that includes 11 new risks this cycle, but alongside 8 that have been marked for closure. I think it would be fair to say that many of those new risks, and indeed closing risks, are related to organisational change. So over the cycle, it's been fairly fast moving, and so the risks that we had at the end of Q1 are very different from the risks at the end of Q2, so that accounts for quite a bit of the change that you see within the report. We do also have a new high-level risk relating to industrial action, and then there's another new one around the maternity neonatal voices partnerships, which we referenced earlier. I would, as always, draw your attention as a board particularly to the high-level risks. That's those that are scoring 15 or above. I think you'll be familiar with many of them, as they are. They've been there for a number of cycles, but it's important that we keep an eye on those. There is a section within the report around standing risks, so you'll be familiar with that terminology, and there are some risks where they're likely to always exist, no matter how well we try and manage them. There are 2 new risks that are proposed as, to be designated as standing risks this time. You might remember at the last cycle I said that we'd started with the high-level ones and we were working our way down. We have identified 2 further risks that relate to information governance, where we are doing everything that we believe we can, but we cannot manage the risk away completely. So they've been discussed through the committees en route and are proposed for including as standing risks. You do have detail included for the first time, summarising the risk discussions that have taken place in the 5 place committees, which I hope is helpful to give you a flavour of those discussions and should triangulate nicely with the AAA reports in terms of those discussions. And that's alongside the reflections that we usually share from executive management team and also from the West Yorkshire committees. So just to remind the board that what we're asking you to do today is to review those risks that are on there, consider whether you are sufficiently assured in respect of those, and then there's also the horizon scanning element. So we have talked a little bit today at various points around risks on the horizon, and we'll make sure we capture those as part of the discussion. Thank you.
Thank you. Okay, thank you for the input there. Questions, comments? Oh, Kim, yeah.
Thank you. I mean, when we look at the dashboard, obviously there's really specific things that we're measuring, and as a board we're reviewing. I just wanted to pick up on the mental health ones, because the one in terms of out of area placements, I think it's really important for us as a board to remember, I know mental health colleagues will remember this, but that there's so much that sits behind those out of area placements in terms of what's going on for people in our communities and what that means for all our services. The reason why I'm saying this is I do think that the 10-year plan is quite light on mental health, and actually there is, you know, a concern always about parity of investment in mental health, when sometimes we see very, very visibly the headlines around ambulance waiting times and A&E performance, but actually less press and publicity around access to mental health services. So behind the out of area placements obviously sits the pressures that sit in our community mental health services. We see that very clearly in the NHS, but also in social care, in children's services, but in the VCSE as well. What we're seeing is a very, very big increase in demand in terms of the VCSE provision, but quite specifically in terms of the acuity and the risk that is now being picked up in some of those VCSE services. So, I just wanted to remind people that behind these sort of performance targets that we review as a board, there's a picture that we aren't seeing, and probably in terms of the data of the pressure that mental health services are under.
A very powerful comment, Kim. Pressure both for services, the individuals within it, and the service users. Bev, earlier you mentioned the fact that you and Debbie's your report was very much high level but with detail, but there was far more detail at provider level. So I wonder if that's the case with mental health as well? That, you know, we have this information, it doesn't come to the board, but it's important for the board to be reminded of it.
I put my other hat on. I'll put my mental health chief exec hat on. So yes, absolutely, we have huge amounts of detail. We know every person who has to go into an out of area bed, we know the reason that they have to go there. And Kim makes a really important point. We focus on the out of area, but actually when you look at mental health, I was talking to you about this, Rob, last week, a lot of the risk sits within the community, actually. And we look at some of the tragic cases that have happened nationally around, I mean, they're rare, but they do happen in people who are sitting in community services. So actually what we do is to look at the whole breadth. So out of areas is maybe a bit of a canary because we've got significant pressure building across our services. But yes, we absolutely look at the breadth of the whole pathway and specialised care that we provide. Mental health is a very broad gamut of provision and actually might be helpful for board to actually maybe have a session on what that looks like actually, because out of areas are just a tiny piece of the services that we provide.
Yeah, exactly. Well made point. To make a note of that. Another task for us to think about, yeah. Is this related to this? Because I've got Jane waiting. No. Let me take Jane first.
Thank you. Question for Jonathan and a couple of risks to ask Laura or others around. So, Jonathan, it'd be good to know where we've got year-to-date adverse financial performance, whether it be bottom line or efficiencies. Interested to understand from your perspective how clear do you think we are in the relevant places as to whether we've got specific actions of how we're going to recover that to hit the forecasts versus there's a hope that things will turn in our direction. So a sense of your views on that would be helpful. And then on the risks, Laura, as you said, a lot of them are there's a lot of new risks, not surprisingly, I guess, because of the development in terms of the organisational change piece. I think it'd be helpful from a board perspective. I'm sure it's there in the detail, but just to hear a little bit, and for members of the public who might be listening in, to hear a little bit about how we're tackling 2552, which was about the National Quality Board position statement, asking us to focus on the impact on quality due to new operating model, and then 2535, is that right? Yeah, risk of prolonged disruption, people starting to disengage from work, etc. What are we doing to actively mitigate to the extent that we feel we can, and what are the sort of key things that we're trying to do in that space? I know they're really complicated and big, but just to sort of, what's the discussion that's been had at SMT around that, please? Thanks. Sort of brief. Yeah, Rob, thank you.
Do you want to do the first one? Sure. I'll do the second one.
Yeah, I'll be very happy to do the first one. Thanks, Jane. So, if the question around what have we done as a result of the sort of distress that we can start, or the risk that we can start to see, either in the year-to-date position or in the overall assessment of risk. One of the immediate steps that we took, which I sort of described as a risk-based approach, is look at the results and the risk at month 4 and set up some very specific meetings with the individual trusts, of which we've had 3 now, and 1 more to come very shortly. And that's been a conversation between the Chair, Chief Exec and Director of Finance of the Trust, mirrored by myself, Rob and Nadra from the ICB. Also in attendance at some of those meetings has been the NHS England North Eastern Yorkshire Regional Director of Finance, as well as the place leads from the ICB. And that's really been around understanding what the current position is, what actions have been taken, what actions could be taken, and where that might lead to in terms of a year-end position. And the focus of that conversation is driven from an assessment of money, but it's ensuring that we take account of all factors, including quality, performance, access, safety, etc. So that's what we are doing to date. And it's probably fair to say we've had mixed levels of assurance back in terms of those conversations. So some we've had that conversation, and it's likely that organisation will now be, well, I say left alone is probably not quite the right language, Jane, but we need to give them the breathing space to do what they need to do. In others, there'll be some follow-up required.
So on the disengagement of staff, the inability to deliver because people are
sidelined or disaffected because of the change process. We've recognised, I think, in the executive management team that rightly in the months since the announcement in March, the first 2 or 3 months, we really just spoke to staff about the change because it was imminent and we were driving the structural changes. As there's been some delay, what we've been moving towards is reinstating the non-organisational change briefing. So we're talking about, well, what difference are we actually making? What is the work doing? We're making sure that we've been considering what does turnover and sickness look like, and actually turnover and sickness are stable. It's about the same or slightly less than last year. At the same time, recognising that because there's vacancy controls, we're probably seeing some potential hotspots in some places, and therefore looking at making sure we're giving staff the tools to do the job, and through the vacancy control process is starting to say, are there some areas where we really need to have a proactive look rather than a reactive response to requests for additional capacity. So that sense of giving people a purpose, connection back to why we're here, keeping the briefings going, making sure we've got the capacity to do the job, and continuously talking about that. And genuinely, I think now, saying, how do we create a sense of excitement about a future which is compelling, with an ICB that's a strategic commissioner, with a region that's a performance manager and a smaller centre and providers working in collaboration, so that people feel connected to something which they can see coming down the track. So there's a lot of work going on, and I think we've talked about whether we reduce some of the risk that's set out there whilst recognising there's still very much issues that we have to address. And Bev probably wants to say something about quality.
Yeah, thanks, Rob. Thanks, Chair. So this is in respect of risk 2552, which is about the potential risk of the inability to meet our statutory responsibilities. So this was assessed anticipating a 50% reduction in capacity across the board, and I've already referenced the LNMS. Currently, we are business as usual. We have in the new structures that have gone to the that are approved to consult upon, we will meet our statutory duties. However, the board will be aware that recently issued good practice guidance, we will be revisiting them. And again, we'll be revisiting them at system level, but also at regional level. And myself and James were at a regional quality committee all day last Friday and discussing this and the ability or inability of some systems to meet their statutory guidance in the new system architecture. In response to the NQB statement that was issued as a result of the announcement to reduce capacity by 50%, we have discussed this at our system quality group, and as I've said, that we are currently business as usual. I think that this is ongoing, and fortunately or unfortunately, given the delays that we're experiencing, we can refine and revisit as required. So I hope that offers some assurance, Jane.
Thank you. A couple of reflections and a question. So the first one is about the LMS risk and just the recognition of the amount of work and effort and change that has already been instigating, and ensuring that we don't lose that as a consequence of some of the risk or the changes that need to take place as a consequence of the change. So some assurance on that and what more we can do, and our offer of support from us as board members, I think, is important. My second question is about risk 2444, I think it was. Laura, I really like the way that you framed in the paper the conversations that EMT have had and some additional mitigations and the triangulation across places. And I noted in the paper you mentioned that several accountable officers have flagged this as a risk and are having conversations. I suppose my question is there more we can do in light of more and more emphasis in the 10-year plan being about patient choice, and is there learning that we could take beyond just this specific issue about how we start to prepare for that and empowering our patients in that space? My final point, and I think the most important one, is that I want everyone to go to page 162 of the pack and just actually really look at the snapshot of what we've done. So Mel said a couple of times, an hour ago, it feels like years ago, Mel, today, but it was about an hour ago, where you said thank you to all our staff. And I really think sometimes we see data, but we don't fully process it. And actually the performance is so good. You know, I mean, nearly half of everyone sees a GP in the same day. We're stagnant on a number of our processes. We're smashing some of our targets. This is what the NHS and the system is set up for. And we're like, yeah, that's how we roll. It's fine. But actually, I think people do need to see and hear it. We need to acknowledge it, not be complacent, but acknowledge it. But also, how do we use this as an opportunity to invigorate the conversations we need to have, Rob, about purpose and hope? That we're starting from a really solid place, and actually there are things we're really good at, and to focus on that, and the fact that we are doing things that are making a difference to people's lives even though we're removed from them, because I think sometimes we forget that.
I think that's a really incredibly good point, how we're making a difference to people's lives, but although we're distanced from them. It's a quotable quote, but I think we really appreciate those comments. Really important. Hannah, did you want to say something?
Yeah, and just to echo that, there are many brilliant services and people are experiencing lots of really positive experiences. I went out on an enter view recently to some learning disability services in Leeds, and it was exceptional, the support that people were giving for that group of people. Saying that though, just to echo what Kim said about mental health and the 10-year plan, I suppose I think it's important we don't lose that focus on mental health. It's before there was a change in the way that we could access GPs, the thing most people talked to us as Local Health Watch was mental health and mental health support. Now it's the variance in trying to access GPs. But I suppose not to lose that, and very early on in the ICB journey, we had a focus on session around people's experience of mental health, and I wonder whether it would be good to revisit that. Not least because there's been lots of good stuff happening in communities around the community mental health transformation as well. But as an ICB, we must not lose the fact that it's recognised as a lack of parity between mental health and physical health. But as a board, we must not lose that focus.
Right, thank you. I'm going to close this item now, but thank you for the reports, and thank you for the discussion, which really is mindful of where we are, where we need to improve, but definitely thinking about our people and staff at the centre of this, and how we motivate, support, and let them know that they're doing a good job, which is highly motivating for them as well. So thank you for this. So we reviewed the corporate risk register. Hopefully we are assured, looked at some of the mitigations, and we've also considered some of the emerging risks on the horizon. I'm pretty sure we'll be seeing that again at the next board. Okay, thank you for that. We've got the committee AAA reports. In the light of the fact that the risks of the report at place were discussed very early on in the meeting, I just wonder if anybody from place wanted to say anything. Therese.
So I'm about to leave. So just to give the board assurance, if you look at our AAA, we've talked about the strategic outline case and the timing. So as we discussed in private, but this is for the public session, we will go through an assurance process at place, Airedale board at place, through Wyatt, and then come back to the board when it's appropriate. So just that assurance, Chair.
Thank you.
And then I must leave.
Brilliant. Thank you very much. Just in terms of leaving, we have some decisions to be made at the end. How are we doing for quality? Okay. We're still okay? Yeah. Okay, thank you. You may leave, Therese. Tim.
Yeah, I think one of the conversations we often have as a board, but perhaps haven't had as much of today, is around health inequality and the importance of keeping the focus on health inequality. And certainly the Leeds Committee, our last meeting, had quite a long session looking at a regular update that we have around health inequalities. And I do think there's something in terms of how we look at our performance and connect it to inequality, which is not easy to do currently. So I think if we really challenge ourselves, do we understand well enough how people who are suffering the broader inequalities in society, how they're doing in terms of their access to GP, their access to mental health? I don't think we're yet as as focused on making that connection as we need to be. And that was part of our conversation in Leeds, among a number of other things, and some really good work we're doing as well. But I think it's probably a challenge for us when we look through these performance things. Is this affecting everybody the same? Because I suspect it isn't.
It's interesting you mentioned that, because at the meeting Rob and I were at yesterday, Healthy Working Lives, there was a lot of discussion around health inequalities, obviously, but also how do we hear those voices and experiences that we're not hearing? So thank you for that.
So I think there were just 3 comments I wanted to make about the Kirklees committee. The first, and I think we had a very diverse meeting, so I think our AAA report shows that. I think one of the key things was the powerful patient story that we had that led into our discussion about neurodiversity services, and that was following on from work that we'd done at the beginning of the year, a deep dive that we'd done looking, and it was supporting some of the changes that we're already implementing. But that was really gratefully received, and I think what was really empowering, and I'm going to say it here, was it was a member of staff and her son that presented, and the realisation that she was working within our organisation, and the majority of people didn't know she was neurodiverse, but it was an absolutely fantastic presentation, really moving for everybody. So that was one of the first things. The second thing, we had a very lengthy discussion about the financial position in Kirklees and the partnership working that's taken place. And there were 2 key things recognised. The first one was that it probably felt that Kirklees were in the strongest position at this time of year that we've ever been, with the controls that are in place around that. And the second that was acknowledged by the partners was the work and input from our staff in a very difficult time to actually keep us in that position and be maintaining the position that we were in. And then the third thing, just to draw attention to, was prior to the meeting, we had a session where we looked at the paediatric service at Mid Yorkshire Hospital and some of the emerging issues that are coming to light. And we've agreed a set of actions and processes for that to now go through, which will be through our quality committees and into West Yorkshire, and then back through the board process. So it's just to make people aware that one will be coming back as well.
Thank you, Chair. I just wanted to sort of highlight that we made a difficult decision based on all of our quality, impact assessment, consultation and safety data at the committee around the permanent closure of the birthing facilities at Pontefract. But I do just want to, be really clear that, we've got a very thriving maternity hub at Pontefract Hospital that the community really, really value. We've had a 92% increase in maternity appointments since 2019 compared to last year. So we don't want the message to get out there that the maternity facilities and postnatal, antenatal care facilities that we've extended, and in terms of family support, breastfeeding services, parent education, everything that we committed to do in the clinical senate has been delivered. So we want that message to be clear. It was the birthing facility only, which was 4 birthing units, not the full range of maternity care that's delivered at Pontefract. So we made that decision on the 9th, as you can see in the AA report, but it's important to acknowledge that today.
Thank you very much, Mel. I think it's always really heartening to hear what's happening at place at board. So thank you for all those reports. And also, I think the board really wishes all the teams all the best, and thank them for the work that they're doing and continuing to do. Okay, so we've received these reports. Thank you very much. So we've got 2 largish items, which I hate saying this, but we need to assume everybody's read the papers and have a very, very brief update and then go into questions. So we have winter planning, 25-26, and the board has shown statements, and it's Deborah Taylor to present.
I'm back again. Okay, so I do hope everybody's read the papers. The first thing
And
I'd
any
like
updates you have?
Yeah, I'm just going to quickly. I just think one of the things I do want to say is I just want to thank everybody's place and all the providers, because it's been quite a lengthy process this time with a lot of templates and requirements to provide the level of assurance. And that also involves the board assurance statement, which I'm here today to provide assurance around the planning that we've done and to get the board assurance statement signed off. So the board assurance statement, we had it for planning last year, those of you that might remember that, and they've brought one out, NHS England have brought one out for winter. And that's about system oversight and assurance that we have considered all the critical elements of winter and that we believe we have got robust plans in place to meet the pressures. I mean, obviously winter always throws up pressures and it is very difficult. I think it's important to know it is very difficult for us to mitigate everything that winter is going to throw at us. But we have 4 individual place plans that are based on our A&E footprints that have all been signed off by either our place committees or our equivalent A&E delivery boards in each place. The ICB needed to do has got the requirement to do the board assurance statement, and all of our providers are required to do one, and they have been working through that, and they have to go to their boards and they will submit them. So we haven't actually seen them. I think it's an important point. They will go directly to NHS England, and next week we will get copies of them. Our board assurance statement covers areas such as our system engagement, quality, winter testing, accountability, risk management and mitigation, our processes through our system coordination centre to provide that command and control during times of extensive pressure, our escalation processes, and to ensure that we are compliant with the NHS checklist, which includes a range of areas such as vaccination, community care, demand and capacity modelling, staffing, discharge, and our on-call and clinical leadership. So through that assurance statement, which I do hope that you feel that we do have robust plans in place, there's still some work going on, and what's really, really good to hear is that we had an extremely good attendance, didn't we, James, at our winter testing event. I think we had the most people there out of the whole region, and there's still some learning that came out of that event, and it's good to hear that a number of our places are going to be redoing that testing of the winter plans in a lot more detail within their places. So even though I'm here today to ask you to sign this off, I think you need to be assured that we've done the work, but there's also the work is ongoing around strengthening those plans as we move into winter. I don't think we can underestimate the amount of scrutiny that we're going to get this winter. There'll be a lot of monitoring on a daily basis. So I'm just going to warn you all now, I might be talking to you all on a regular basis. But I think the places and the organisation and all of our providers have done some extremely detailed plans, and we're about as prepared as we possibly can be. We've just got our fingers and legs crossed. As always in winter.
Thank you, Deborah. Obviously, we are the last people to see this, but we appreciate all the work that's gone into it and the committees and groups it's had to go through to get this far. Anything to add or any comments, questions? Victoria?
Thank you, Chair, and thank you, Deborah. Couple of comments. It was great to see in the prevention section that there was so much in there on vaccination, which obviously we want to see. I guess I'm really aware of how much system work goes on in terms of mitigating the risk of cold. And the work that we do as public health departments with NHS colleagues around people who live in cold homes, and cold being a major driver of death and poor health in winter. I know there's loads of work going on winter warmth, really operational, stuff. We do loads in Leeds. I'm sure people do lots across the areas. So it'd be really good to see that reflected in here, because it does really demonstrate that system join up. And obviously we can really get into some of the wider determinants of health there around housing and health, and working with housing colleagues where we know where our communities are with the most risk. Which leads on to my second point, that this, I think, similar to Tim's recent comment around health inequalities weaving through this feels
really critical around the health inequalities piece, particularly around the preventative work. So I think that would be helpful to emphasise more. And again, just emphasising that relationship with public health teams and public health colleagues around, there's mention of data trends around planning assumptions, which we can work with colleagues around. But there is a big operational kind of delivery at the front end of this, which is about working with local public health teams and local authority colleagues. So, yeah, it'd be great to be able to see that and talk about that more in the narrative. Thank you, Deborah.
Thank you for that, Victoria. Clearly another partnership delivery here. Yeah. Fatima?
Victoria Eaton stole all my questions.
That I think what will be really helpful is if we can share the individual plans, because all of that details in those plans. This is just the board assurance statement that we need to get signed off at the board, but I think all places will have seen their plans. They developed their plans, but I know they will be fine that we can actually share all the individual plans where all those details are in there. So I'm quite happy to do that.
Just for the benefit of the record, Victoria already asked my questions, Chair. Thank you.
I thought you might have, Fatima. Yeah, good point. And I think you've made a final comment about before we go into the assurance.
Yeah, I think just to add my thanks to everyone who's been involved in this, and just to remind the board that our winter planning starts in March, and you know, on the back of the previous winter we do a review and then get into the winter planning processes for the rest of the year, which is then overlaid by some national additional good practice and then some assurance. And I think I've got no hesitation in recommending the assurance to the board.
So, not to sound like a broken record on vaccinations, but I suppose I just want to kind of highlight, not only in terms of working with our communities, but actually one thing I suppose hasn't come across today, but it is in the papers, is kind of vaccinations of our staff, our health and care, social care workers as well. So I suppose it's just emphasising it's part of our winter planning. There's a real importance of our organisations to kind of help enable that there. I think from a system point of view and system leadership point of view across health and care, we have put out various messages and comms, and we'll carry on with that in terms of helping to support that message, but recognise a lot of that work is going to be happening both in our organisations as well as our communities. So I just want to mention that.
Thank you, James. And vaccination very clearly has been another theme that's run through today, so thank you for that. So are we ready to sign off the board assurance statements? Yes, great. We assured on the approach to developing the plan and support capacity and resilience for coming winter and meet the national winter policies and requirements, and assure that there are robust surge and escalation processes in place, and especially to manage in times of pressure supported by on-call arrangements. I'm sure we'll be seeing an update on this at the next board, so yeah, thank you, Deborah. We're now going to go on to the West Yorkshire ICB Green Plan, and it's going to be Ian Holmes, and welcome to Lucy Kempster.
Yes, thanks. Thanks very much, Nadra. I will be brief because I'm conscious of the time, but this is an important item. It connects to one of our 10 ambitions as an integrated care system. So currently ICBs do have a statutory responsibility around environmental sustainability. As part of this, we're required to produce a green plan every 3 years. National guidance around the production of a green plan was produced in February. We then received a set of information in March through to May, which threw into some confusion, I think it's fair to say, our roles and responsibilities in relation to the environmental sustainability agenda. So the document that came out in May, the ICB blueprint, said that ICBs wouldn't have a role around environmental sustainability. Subsequently, we've heard that we may have a role. But clearly this is a really important issue and a really important health issue in West Yorkshire. Until we're told otherwise, we'll still continue to play a leadership role in that space. Lucy's worked really hard with partners over the summer to develop this plan in response to national guidance. It has been a collaborative effort. We've got a network of sort of green plan leads across the system that we work really closely with. And I think what you can see in the document is we've really tried to frame the activities in the context of what a strategic commissioner might do in the future, while recognising that some parts of the national guidance around workforce leadership, digital leadership, that we do need to attend to, while recognising that those may go elsewhere. So what we're after is support for the plan as written, recognising that this will need to be a little bit agile as we move through the next stages of the organisational change programme, and some of those functions we might need to work with region or providers in terms of how they get delivered in the future. I'll pause there, and Lucy, I don't know if there's anything else that you want to add, given the time we've got.
Thank you. Yeah, my name is Lucy Kempster and I'm a public health registrar working at the ICB. I was just going to highlight a few key points in the development of the plan and the aims, but appreciate Ian's kindly touched on most of them. Just to highlight again, the NHS has net zero ambitions for direct emissions by 2040 and indirect emissions by 2045, and we have statutory duties to try to meet these requirements. The Green Plan outlines the progress we've made so far and how we are going to continue working towards these targets over the next 3 years. And as Ian's mentioned, we've worked with our partners to shape this plan through regular meetings with trusts and with the wider Greener NHS team. In the guidance this time, there were specific actions for ICBs and trusts, and so this plan describes the actions we will take as system leaders and how we will continue to work with our partners to drive forward our ambition, such as working with West Yorkshire Combined Authority on wider determinants of health and describing our commissioning intentions to support providers to deliver their actions as well. We've also reflected our wider partnership ambitions, such as referring to antimicrobial resistance and health inequalities. And we've really tried to take a focus on the co-benefits of action, so commissioning care that is good for health, good for the environment, and is also financially sustainable as well. As Ian's mentioned, we recognise the changing landscape, but we have tried to develop this plan with realistic actions that we can take as strategic commissioners going forward. And just to summarise, this plan outlines our commitment and system-wide approach to our statutory duties, progressing a coordinated action to achieve sustainable and climate-resilient healthcare system in West Yorkshire. And so we've come here today to ask for approval of the Green Plan and for your support and commitment for our responsibility to deliver these actions. Thank you.
Thank you, Chair. Really welcome the paper and its content and key messages. Thank you. Just to emphasise, we in the lead system we've been having very specific conversations around heat and health this year because it's been the topic of my Director of Public Health annual report. And just to, in terms of the parallel with the conversation we just had around winter and cold, we know that the day with the most temperature-related deaths is actually the 19th of July 2022, where we saw 40-degree temperature in West Yorkshire. There is something really critical around addressing heat in the same way we're addressing cold, and actually having the systems around that all year, around weather-related health. So I welcome the reference within the report on that. Thank you very much. And also the point around health inequality is we know this doesn't affect our population equally. So we know people who live in densely populated places, city centres are often around 8 degrees warmer than rural areas and suburbs. So and we have people with multiple vulnerabilities. So absolutely, you know, this agenda is a health inequalities agenda, and we know the evidence is really quite powerful around it. So I think that it's a very brief paper covering a very huge topic, and but there's a lot for us to look at in terms of a sustainable health and care system going forward. So really welcome the opportunity to further discuss different elements of this work in the future. Thank you.
Thank you, Victoria. I think Majid has a question.
Yeah, thank you. Yeah, just looking at the plan and the actions, it'd be good to see if we had more measurable actions in terms of when we talk about reducing something, from what to what, etc. Because I mean, if you look at some of them, like it says, installing LED lighting, double glazed windows, etc. The measures evidence of implementing changes. It's not really quantifiable or knowing how we actually doing it, are we actually making a difference. So it'd be good if more of these actions could actually be quantifiable. So when we come back in a year, 2 years, say, well, actually, that's the actual difference we've made, an impact we've had.
Thank you, and thank you for your comments. I agree with the actions, and having quantifiable measures is best. I guess just to mention that a lot of the more measurable actions are more specific to trusts, and so we've tried to focus on more what the ICB is doing. And so there are, for some, such as the LED lighting, there are more measurable targets, but because they're more designed for the trusts, I haven't included all of those. But perhaps maybe referencing the more specific ones for trusts would be helpful. Thank you.
I think even the ICB ones, if some of them feel a bit generic or vague, if you could quantify a little bit more, that would be good. Thank you.
Jonathan?
Thank you. Sorry, thank you. Really good paper, so thanks, Lucy. I guess mine's sort of similar-ish to Majid's point, and I noticed 1.1 is, action 1.1 is determine who the board SRO will be for the Green Plan. But there's something about across those 40 or 50 actions, who is the lead board director on them. So I can see there's at least 2 that will fall to me, for instance. And I'm sure you've sort of engaged with people in the team to help shape those up. But I suppose there's just that bit about the ownership at the board level, because if we're clear about that, we can then translate those into personal objectives and team objectives, and then they'll happen. So I just think there's that sharpening up to make sure that within the ICB, not the wider stuff, because I think there's something about what our responsibilities in ICB, but can we be absolutely clear about who round the exec management team table is taking the lead for which, and then we can operationalise them.
Fatima?
Hello Lucy, I'm Fatima Khan-Shah, the West Yorkshire Inclusivity Champion. Really great paper, and it kind of builds on what Jonathan was just saying about how do we create a movement of change to support the aspirations of your plan. So there will be people that have got responsibilities to do stuff, but is there an opportunity to create ambassadors to get people behind what you're trying to do as well? Very similar to sort of like the digital ambassador scheme that we've seen. Because I still think there are certain individuals, and going back to sort of the point that was made earlier regarding sort of poverty and inequalities, there's something about the messengers being able to make this relatable for everybody, and it's not just seen as someone's tokenistic job, but actually pivotal to what we're trying to create for the future. Happy to have a chat with you offline about that, if that's okay.
Thank you, and I think that's really important because, like you say, this is a huge topic, and it's not just sustainability lead's role. And I think in terms of trying to get a wider audience, focusing on these co-benefits that other people in the system can relate more to, if it's financial or health, is really helpful. But yeah, that would be really good to have a chat. Thank you.
It's quite interesting, in a recent survey of young people's views, climate change was one of the 2 top priorities on young people's agendas going forward. So it's really important that we at the ICB take a lead on this as well. If you wanted to come in, final words?
Yeah, so we know there's overwhelming evidence of climate change happening, and overwhelming evidence of the impact of climate change on health. And it's good to see the plan. It would have been good to have a bit more time to discuss and debate it here, but we don't have that time. If we did, I think we'd probably want to explore 2 things, one of which has been touched upon already, really, which is what are the measurable actions that we'll take which will directly impact or mitigate the consequences of climate change, and how much do they cost? And then the second is, whose responsibility is it to do this now? And I think the first of those should be linked to the planning process that we're about to go through, with the 3-year plans and the planning guidance that comes out. And the second will become clearer as we work with the region on the model region and NHS England, etc. So I think, unfortunately, I think we can only agree this in principle, and then it goes into those processes because of the uncertainty about who's leading, and because we've got a planning process to go through. And some of the things in here that we want to do are subject to current prioritisation, things like the fellowship scheme, for example. So I very much commend the plan for adoption, but it does need to go through the planning process and to be assured around the organisational change.
So can we approve on the basis that it goes through the planning process and links up with the organisational change? Okay, thank you. So now we're on to 22, changes to financial scheme of delegation. The next 2 items are for decisions, so we do need to be quorate for these. Jonathan, you're going to take us through this so they can approve? We're fighting over to do this?
We'll say, I think
well, you can have one each.
No, I think I'm sure if I miss anything, Laura will pick up. So this is these are a series of changes to the financial scheme of delegation, which is part of our governance handbook. It's a recommendation from the Finance Investment Performance Committee that considered the changes at the start of September. I suppose in short, it's changes that relate to the Procurement Act 2023, the Provider Selection Regime Arrangements 2024, and also the introduction of a new general ledger system from the 1st of October 2025, and it seeks to clarify processes. It seeks to make budget accountability and invoice approval limits consistent, and it's really there to tidy up and to make sure that all those various sort of pieces of legislation and guidance speak to one another.
Okay, any question into approval? No? Okay, can we approve? Okay, thank you. Thank you very much. Thank you, Jonathan. Corporate policies, Laura.
Yeah, thank you. So we're asking the board today to approve the review of the fit and proper person policy. It's one of the very few that's reserved to the board for approval. You first looked at it last September, so we had an annual review as it was a new policy. We're not recommending any changes. We believe it remains fit for purpose, and members of the Audit Committee and Remuneration and Nomination Committee were given the opportunity to comment, and again there was nothing specific raised for bringing to the board, so just seeking approval today, please.
Any comments? No? Can we approve? Great. Thank you. Thank you, Laura. So we haven't had any other items for business identified. The date of our next meeting is scheduled for Tuesday, the 16th of December, 2025, and will be held at the Bradford Arts Centre. I'd like to thank the board for their contributions today, and for all our people and staff who've brought fantastic papers, updated us on events that are happening, and also having to deal with lots of very difficult things on a number of different levels. So thank you all. If you take messages back to your staff teams as well. And to those of you who've been listening or viewing through the live stream, just to let you know that the morning of the 15th of December is the final time that you can send us your questions. And the agenda and meeting documents, etc., will actually be in the public domain on the 9th of December. So we look forward to hosting you again. And for those of you who've come physically, thank you very much, and hopefully see you next time. So thank you all. Safe journey.